Okay, I honestly don't know, but I presume I'm live. Micah, can you give me feedback on that?
You are live.
Okay, fantastic. Let me switch to the screen and can I share?
You have controls. Yeah.
Okay, fantastic. And just because I can't see what you guys are seeing, but I presume you can now see my slides. Are we good?
We are good.
Fantastic. Thank you. First of all, I want to thank the ACP and the committee that decided this. When I received the phone call, I could hardly believe it. And I thank you for this honor. I'm humbled by it. And as we all know, we don't do this alone. It's a team effort. And I think that's incredibly important. I had not heard Tom's letter. That's very humbling and not quite accurate. Tom's a brilliant guy, and I learned a tremendous amount from Tom as my first clinic attending. In fact, part of what I was going to talk about today was just that. I don't have any real disclaimers. The only outside revenue I have is I do work for the ACP as editor of their newsletter. I've done that since 2012. So my objectives, as any educator, I'm supposed to have objectives. These are my objectives today. I want to recognize and thank the people that made my career possible. I want to discuss a little bit about my teaching strategies and tactics and things that I have found that work. I want to talk a little bit about what to teach, how to teach, and setting that stage. I think that's incredibly important to do so. And then some of my methods. I don't have all the answers. I think that's important to recognize that. We all know that, but I have had a few years of experience doing this. And finally, I want to recognize my team and the colleagues that I've had, and we'll show those in a bit. So I hope you can see my pointer, and Carol or Micah, I presume my pointer is in the upper left-hand corner. That's Mike Sartorius. He was my kind of mentor at coming out of family medicine. I had the opportunity to work with him. He had significant impact on my career and was my co-director of the primary care program for 30 years until he just recently stepped down as chair. Second picture on here is Tom Tape. Tom Tape, I hope you all have had a chance to interact with. If you haven't, you want to try to. He's a wonderful individual, heavily invested in my career and helped me be successful. He first was my clinic attending, as he pointed out. He went on to be my friend and then my colleague and then ultimately my boss. And he has really helped me in my career the entire time. LeeRoy Meyer, any of you that are over a certain age had the opportunity to work with LeeRoy, at least I hope you did. He was truly a legendary educator. I had the privilege of being both his student, his resident, and then ultimately his colleague. Much of what we do here at Nebraska Internal Medicine, LeeRoy began, and it's been my privilege to continue that legacy. Next person up here, last person on the top row is Jim Odell, my brother. He gave me a job when I had to switch from family medicine to internal medicine. He and Dr. Mike Sorrell, who's down here, said, well, there's no money, there's no job, there's no opportunities, but Sorrell says, we'll make one. And so I had the privilege of coming up to be a medicine resident, and then ultimately I was Mike Sorrell's last chief resident. Jim has obviously been very influential in my career. For many years, he ran the internal medicine residency for 35 years, recently stepping down from that. And obviously, he's my big brother. Bob Waldman, wonderful guy. He, for whatever reason, allowed this upstart chief resident to start a residency program called the Primary Care Program, and Mike Sartorius and I ran that, and I still have the opportunity to run it. But Bob was the dean of the medical school at the time. I didn't realize how rare he really was at the time. Jim Armitage, wonderful man, went on to be my chair and dean and friend. And if you know him, he always aspires to make you the best you can be. And his quote was to get famous. Now, I'm afraid I let him down on that note, but Jim did his best to facilitate my career, and I always will be appreciative of that. Lynn Clausen was also my chair for many years, and I had a career decision to make, and Lynn helped me through that and kept me doing what I was doing, and I've always been grateful for that as I stayed doing the educational and in the trenches that I currently do. And finally, Dr. Romberger, Deb Romberger, wonderful individual also, has allowed me to continue and help guide our transition and develop the new team to replace people in internal medicine. And she's allowed me to continue to do that. So I'm grateful for that. I'm grateful for my Christian faith and its servant-oriented approach. It's been very important to my career, carried me through many difficult times. My lovely wife, who has put up with me through it all. I can't count the number of late dinners, engagements that I've missed, things I had to do, writing talks, mentoring students, residents, etc. But I appreciate her for all her support and her love. My family, and as I go through this is my oldest son, Matt, Jack, Paul, my daughter, Allie, her husband, Brian. And then, of course, when I was going to give this talk, Allie was concerned because we weren't going to have Lucy in it. And so their new picture, and if I'm spoiling their Christmas card, I apologize, but that's going to be their Christmas card with Lucy in it. So I want to thank them for all their support and love. And then finally, I need to thank my patients, because they have literally seen hundreds of medical students over the years and graciously allowed the students and residents to participate in their care. And their insight is invaluable in terms of helping students and residents become more effective physicians. So switching gears to what to teach. Any of you that lived through the recent fiasco here at UNMC, where we had a cyber attack and the computer went down, had a lesson in what I kind of try to live in, and that is you have to teach the fundamentals. You have to know where your students are at. Who knew that our current residents had never written a prescription and didn't know how? Who knew that they'd never admitted a patient without a computer? Can you do that? Some of that comes out of some of the videos that were available when Epic was first launched, but suffice to say, it's humbling. But it helps illustrate the point that I want to make, that you have to be in the trenches, in the basics, and know where the students are, whether they're students, residents, or fellow faculty, to know where we should be teaching, what we should be teaching. So my philosophy has always been to aim for a Gump. No, it's not the character that Tom Hanks immortalized with Forrest Gump, not that dull-witted individual, but Gump, all capitals. It's an acronym. I had the privilege to serve on the Step 3 committee for USMLE for almost a decade. And we would sit around tables and discuss, okay, so what should we expect of that first-year resident? What do they need to know to allow the patient to do well until somebody else can arrive and help them? And that's really where my career has mostly been made, in that transition zone between medical school and residency. Now, obviously, I spent a lot of time with the junior clerkship and did that for many, many, many years. But as they're learning to become doctors, and so learning to know what you need to teach them is important, and making sure that you aim for the right level. I think the best way to do that's the Socratic method. Now, of course, those of us old enough to say that, well, what's the Socratic method? We think of pimping. And the question is that what we're talking about? Well, if you've tried or watched certain attendings ask questions, you'll see this anxiety attack. Now, this was true even when I was a student, and LeeRoy would ask me questions. We would hide it a little bit better than millennials do, but it's true today, and it's even more true today. And so how do we address this anxiety? How do we get past that? For heaven's sakes, I've had to catch students when asked a question on rounds that then were fainting so they wouldn't hurt themselves. So I think maybe one way of defining what Socratic method is to define what pimping is and then go from there. And this was immortalized in Mercanti's article of 1989, where he talked about proper pimping inculcates the intern with a profound and abiding respect for his attending physician, while ridding the intern of needless self-esteem. Furthermore, after being pimped, he is drained of the desire to ask new questions. Now, one of the things I don't like about Zoom is you can't hear or read your audience, and I think that's important, but hopefully you find that somewhat humorous, because we certainly have. But what I really want to get you to recognize is that the Socratic method isn't really pimping, and I want to draw some distinctions between the two. Specifically, Socratic method, you need to focus on relevant topics that are important to your learners. I've been blessed to be mostly instructing people on things that is just evidently so important, and they recognize that importance, and so they have such face validity. I don't have a problem. You get the students to express what they do know, and I think that's important. What do they know and what do they not know? And I've always used a technique that I refer to as sounding. Now, sounding actually comes out of a riverboat term, and this is a Mississippi riverboat. If all of you know who Samuel Clemens was, and of course he took on the pen name Mark Twain. Well, Mark Twain is actually the call of the riverboat captain for 12 feet deep. A Mark Twain means a full 12 feet. So the riverboat had plenty of room. But what I'm really doing with this technique is I'm sounding. I'm finding the bottom. I'm finding where you need to build from and where you need to start. You ask questions that formulate to get the student to synthesize knowledge, and then ultimately try to get them to pull that together. In contrast, pimping is often teacher-generated questions. They may be relevant, they may not be. They emphasize what the student do not know. And finally, questions are formulated to expose ignorance. That's the classic pimping. Now, obviously, most people are somewhere in between there. But I think when we focus on those things, that's important because that helps us guide how we ask questions. I think it's also very important to set the stage and recognize what that's all about. There are teachable moments and there aren't teachable moments. I know that this morning when I was making rounds and my team's post-call, and they've had to admit several patients overnight, and they had a rapid response in the middle of the night, that my time was limited, that I could get something done, and you have to be careful of that. It's best if you're using something that's patient-centered. In our world, obviously that's relatively easy, but it doesn't even have to be a current case. If you're working in a small group room, you can use an archive case, and that works. But it needs to have, that makes it real, and that's important for your learners. And then finally, you need to be able to read the room. So for instance, I could tell this morning when my time was growing short that we need to get things done, even though they were receptive to what I happened to be talking about this morning. I think it's also critically important to create psychological safety in the room. Now, what's that all about? I used to call this modeling it's okay not to know. And then I went to a conference, late 90s, and a gal named Ann Edmondson was talking about psychological safety, and it's exactly the concept that I had been talking about, but I hadn't used those fancy terms. I just called it it's okay not to know. How do you do this? How do you get, how do you humanize yourself to your learners? And I often think maybe the best way is to tell a self-facing anecdote or story. And it's even better if maybe you didn't manage it perfectly, or you learned something in the process. And I think we've all can come up with those pretty easily. Medicine is nothing but humbling, and we all know that, those that are in the trenches. I always also stress the uncertainty of clinical medicine. You know, nobody knows it all, but in addition to that, we don't know it all. And how often is the knowledge that we thought we knew wrong? And I think that gets us at this quote from Socrates. And that is to know that you know nothing, that it is the meaning of true knowledge. And what it really hopefully makes us all lifelong learners and question what we know and what we don't. How do we do this? Well, I think sounding is important, but I can't do it in an intimidating manner. I have to find where their footings are. And then once they start answering questions correctly, I know where they're at, and I can build from that. This is not a process that's done in a minute or two. It takes a while. You then can build on that foundation and get them to realize they have a bunch of information, but they have to integrate it, whether that be lab or x-ray or physical, and pull it all together. Get them to get that together and create that aha moment. And it's just fun to see the learner's eyes open up. And this happens whether it's a student or a resident or even a colleague. I always stress thinking physiologically or critically. Why? Because we often don't know exactly what we're doing in medicine. We don't have a firm diagnosis, but you've got to try to figure out, and thinking physiologically the best way I know. My mentor, and those of you that remember him calling it out, was LeeRoy Meyer. Constantly was saying cerebrate to the students. And many of us can remember that, and probably something we'll never forget. You have to help them develop a working diagnosis. When you're taking care of a patient, nothing paralyzes an intern more than not having a diagnosis to work from. They have to be able to alter that, rethink that diagnosis when new data is available. And its best is you can get that learner to think out loud. You can quickly address what they know and what they don't know, but they won't let you inside their head unless they know that it's okay, that it's safe. And I think that's important that we all learn how to do that as best we can. If I can get the learner to think out loud, I have them do that with their patients. I have many a resident who is very shy personally, but they can think out loud to their patients, and that helps them connect with their patients. I think that's important. And finally, what are we really doing? We're building competence. And as we build that competence, they get confidence. And I think that's important. We know we can't give confidence, but we can help them achieve it. What I've talked about really works best in small group rooms. This is a classroom. There's actually about a dozen students in here at any one time. This is the old educational room on 5 West in University Hospital. It looked like this for 25 years. We finally got it remodeled. Thank you to my department for doing that. The college didn't, but we did. You can see the old video camera. Many of you probably remember that. Dan McGuay just retired, those of you that knew him. Another format that this setting works well is in our small group cases. This is in our LeeRoy Meyer Center. His picture's there on the wall, but this is a group of kids, students working through the high impact curriculum that LeeRoy and I developed clear back in about '92. It works in Zoom rooms too. So we've all learned how to adapt and do different things. And this is a group from this summer. And we had to come up with specific Zoom room rules. So I wasn't experiencing, they weren't experiencing what you are today, which is a dead Zoom room where I can't hear or see my audience at the moment. And so we had them have their cameras on at all times. We had their microphones on, and I could pan the audience or the in the gallery view, and I could hear them talk or laugh or whatever. We did ultimately make exceptions in that we had them turn off their microphones if they had a crying baby or a barking dog. Who knew you'd have that problem? This also works well on rounds. And I always stress that learner's job is to replace the folks at the next level. So that you get these junior students to replace the sub-I to replace the interns to replace the senior resident. And the senior resident's job, of course, is to replace the attending. And then the attending doesn't have to come to work. And I always tell them when I do this on my rounds is that, hey, I'm getting old and you're going to need to replace me and kick me out the door. They haven't done it yet, but I'm sure that's coming. Finally, again, none of us do this alone. it's been my privilege to work with some very talented educators. And the first one I want to call attention to is Dr. Scott Neumeister. He also was my student years ago, did the primary care program, but he's a nationally recognized educator in his own right. He's been with us 20 years. Jen Parker here in the middle. When I called her to my office and asked her about if she'd be interested in helping us do student education, I told her she was my #1 draft choice, and she never disappointed. So Jen's been a wonderful member of our team too. Nate Anderson's a more recent addition. He took my place as junior clerkship director a couple of years ago, has done a fantastic job. We welcome Nate, and he's doing a great job with the students. And then in my current role, Ray Witt is working as internal medicine's senior student director. We call it a CST director. And she's a great addition. And then Jill Zabi is our last picture here. And Jill is not only a CST co-director, but she directs our RPC, which stands for our residency preparatory course that all senior students now go through in April, right before they graduate. I thank you for giving me a few minutes to talk. I'd be glad to take any questions. I know that you probably had an eye on this screen and what's going on in the football game, which I don't know, and I didn't allow myself to know. But I'd be glad to answer any questions. And at this point, Cindy, I can't see the chat, but I'm going to stop sharing. If there are questions, Micah, can you help me with that?
Yes, thanks, Dave, for that presentation. It's been an honor for me to be able to sort of stand on the sidelines and soak up some of your approaches and try to implement them, not as perfectly as you have. I'm assuming when you're talking about the football game, you're talking about the Kansas State-Kansas football game. Just to be clear.
Spoken as a true Jayhawk that you are. I mean, excuse me.
Wildcat. Yeah.
Wildcat that you are. Wildcat that you are. I don't have a clue when K-State's playing, but any of you that doubt it, Micah's office is decorated in purple.
It is.
Now, if you notice, I have a red tie on that my daughter gave me many, many years ago in honor of the Huskers. But
so if any individuals have questions, they can place those in the chat. We'd be happy to entertain those. I wonder, Dave, if you could talk a little bit about acknowledging that the time that you have on rounds has been sort of compressed over the years. Some of that's related to ACGME rules. Some of that's just the hospital is a much different environment than what it used to be 5, 10, 15, 20 years ago. Maybe some nuggets of how you try to incorporate those teaching opportunities on rounds, and if that's changed or evolved at all as different restrictions have come into play.
Well, obviously our world has done nothing but get more complicated, and we all know that. The computer has changed it, but it's also helped in some respects. I always viewed the computer as being my aid and my ace in the hole because it could analyze data very, very quickly. And that helped me take better care of people. But on rounds, it also has allowed me not to have to write notes because, as you know, Micah, I mean, how many different units do you make rounds in every day?
Right, yeah.
And you're running around, and in the old days, we had to write notes right there, or you had to go back, and you're going to 7, 8 different places. So in a sense, the computer has helped me allow me to write my notes sitting in one station because I don't have to go back to the physical location if I've already taken care of patients. So that's one way that I think it's helped. I use my team rounding room more for education than I do in the hallways with patient confidentiality and everything else. That doesn't mean I don't illustrate things. We were pointing out spiders this morning. Spider angioma is on a patient this morning because my students, and to be honest, my resident didn't recognize what they were. And so, you still use that. I think that you have to be careful. I often will foreshadow a topic, which helps get that anxiety because they've read about it. I know they have, which is a good thing. You want them to be successful, but they may not get the whole gist of it. And I think that's why it's important to, shadow that you're going to go there and then come back and do it and help them with their understanding of that. I think that's important. And again, there are days that we're busier than not, and I use those days that we're less busy to try to do the educational stuff. I also, for many, many years, any of you that were around know that I was actually medical director for a long time of cardiac step-down unit at the university in Clarkson. But a number of years ago now, I moved to VA, and things are a little slower there, which helps in terms of giving us a little more educational time. So I like that. I got also the chance to do morning report yesterday, and that's always fun.
Yeah. So we do have a couple questions that are in the chat. So Dr. Kosmiyar is wanting to know any additional tips for adapting teaching conferences via Zoom, since you are now an expert on Zoom education.
And I chuckle, of course, because none of us are experts and we're all learning as we go. It's been an interesting environment to change. I really, if your Zoom rooms are small enough that you can see their eyes, I can do that just about as well as I could do in a conference room. I really can, because that close-up picture of them, they may not recognize it, allows you to kind of see what's going on. So I like the idea that you have that video camera on them at all times. I like the idea of having that mic on it. It improves spontaneity. Just like you and I are having a conversation, that's exactly what you can do in a Zoom room. I will also say that having them prepared, I know they have additional resources available to them. That's the difference between today's students and where we were, is, you know, we had to go off and look it up. They have Google, and they can get information. They don't have understanding always, but they can get information very quickly. And I think that's where we need to focus. In terms of how do you build confidence, I see that as the next question. That's always a challenge. But that's part of the reason I always start with where they are and then try to build from that. Because if I'm at a higher level than they are, anything I say is really lost on them. We all know what happens when you give a patient too many things to think about. Once you give that cancer diagnosis, you're not going to get anything else accomplished that day. With that student, you got to get them over that initial anxiety. If they're so anxious, they can't process you, it's self-defeating. And that's why I talk about reading the room. I had a junior this year that got really, really anxious when they presented. And so we worked on it. We worked on structure. And all of a sudden, the light bulb went on and she realized that she was going to make mistakes, but it was okay. And she's a gifted individual. It's just needed time. So I think that's just investment of time, and I think students always are going to appreciate that investment of time.
Yeah, the light bulb moment that you get as an educator when a medical student or resident sort of gets it is exhilarating for sure. Well, the most important thing that Dr. Romberger let me know is that the Wildcats are up 10-0 over the Jayhawks. So.
Well, I'm glad you are happy, Micah. Dr. Have a great day.
Dr. O'Dell, I appreciate the time, and thank you for all your years of service, both at the Med Center, but also with the ACP chapter